Good afternoon, everyone. I'm Nirav Shah, the director of the Maine CDC. I'm joined this afternoon by Commissioner Jean Lambrou from Maine's Department of Health and Human Services. Commissioner Lambrou and I are pleased to be with everyone today to talk with you about where we are with COVID-19 for today, Wednesday, February 2nd, 2022. I'll begin by talking about where we stand from a public health and epidemiology perspective, turn things over to the Commissioner for some updates on testing, and then talk about some changes that we're making here at the state of Maine. We begin today's update, however, on yet another sad note. The Maine CDC is reporting 8 additional COVID-related deaths today, including 3 residents of Cumberland County, 1 resident of Franklin County, 1 resident of Penobscot County, 2 residents of Somerset County, and 1 resident of York County. 6 were female and 2 were male. 1 was in their 50s, another in their 60s, 3 in their 70s, and another 3 in their 80s. These deaths bring the total number of deaths associated with COVID-19 in Maine to now 1,759. We'd like to take a moment to offer our condolences to the friends, family members, and communities of all of those who have been affected. As of this morning, Maine CDC had recorded 177,099 total cases of COVID-19. The backlog of positive cases that are awaiting processing stands at 58,000 lab results. Maine CDC is continuing its work on making sure we can tackle that backlog. But this is an occasion to again discuss the metrics that tell us what's going on with the pandemic on a day-to-day, week-to-week, and month-to-month basis. For example, we've previously talked about things like hospitalizations and wastewater testing. More data on the wastewater front will be coming out later this week or early next week. But another metric that we use here at the Maine CDC is simply the number of positive test results that we receive every single day. Those numbers, which are on our website, show a decrease in the rate of positive results that are coming into the Maine CDC every day. Right now, over the past 7 days, Maine CDC has received 1,665 positive laboratory results for COVID-19 every day for the past 7 days. But that's actually down from 2,500 a day in the prior 7-day block. This number, the number of positive test results that are reported every day, for those who are looking for a day-to-day metric, is a better one than what we've talked about before, given the limitations right now in who is getting tested and where they may be going to get tested, as well as the backlog. Turning next to hospitalizations. Right now in Maine, there are 344 people hospitalized with COVID-19. However, 2 weeks ago, that number stood at 411 people. That is to say, over the course of one incubation period, hospitalizations have come down by 67 fewer people than just 2 weeks ago. If we take a look at the breakdown of that, the numbers are even more revealing. For example, there are currently 83 people in the ICU right now, down from 102 just 2 weeks ago, 19 fewer people in the ICU. Similarly, for non-ICU patients, there are 261 people hospitalized right now. But 2 weeks ago, that number stood at 309, 48 fewer people in non-ICU beds now as compared to 2 weeks ago. Similarly, with ventilator use, there are 38 people who are on ventilators with COVID-19, whereas 2 weeks ago, that number stood at 53. Now, these reductions in hospitalizations are significant and meaningful, but make no mistake, 344 people in the hospital is a high number. The trend, however, is encouraging and represents a somewhat reduced strain on hospitals, even though they are still under very significant strain. This reduction in hospitalizations may also be a sign that Omicron is waning. However, it is too early to tell for sure. Turning next to testing. The PCR positivity rate right now in Maine stands at 13.7% on a 7-day basis. There too, we have seen a significant reduction. 2 weeks ago, the 7-day PCR positivity rate stood at 21.2%. But again, today, it now stands at 13.7%. The trend as well is encouraging there. We are looking for additional data to know where this goes, as well as how much lower it may go. Keeping in mind that numbers like 344 hospitalizations and PCR positivity rates of 13, 14% are still higher than almost at any point in the pandemic. Turning next to some updates around vaccines and vaccinations. Right now, Maine is providing 2,370 COVID-19 vaccine shots every single day over the past 7 days. As a result of that hard work, 77.6% of the entire population of Maine is fully vaccinated, and just over 52% of the entire population that are fully vaccinated have received their booster. There's other encouraging news on the vaccine front. Moderna's COVID-19 vaccine received full FDA approval on Monday, specifically for those over the age of 18. Officially, that vaccine is now known by its commercial name, Spikevax. But we'll always know it by its original name, the Moderna vaccine. Another piece of good news is that the US FDA is working with Pfizer to authorize Pfizer's vaccine for children between the ages of 6 months and 5 years. And we've talked about this a few times during these briefings. The Omicron surge has led to an increase in pediatric cases of COVID-19, as well as pediatric hospitalizations across the United States. Thus, there is urgency among public health officials at the federal level to make a vaccine available for this youngest group. The US FDA is working with Pfizer to review their data and potentially authorize the vaccine as soon as early March. As we have throughout the pandemic, we will be monitoring the situation and will be ready if or when that vaccine is authorized by the FDA. Speaking of which, a few updates on vaccine availability. Vaccines continue to be available across the state. Here are just a few of the larger sites that are still in operation. The site in Sanford, operated by the York County EMA, is open Tuesday and Thursday from 1 p.m. to 7 p.m. and all day Saturday from 8 a.m. until 4 p.m. Likewise, the Auburn Mall, operated in partnership with Central Maine Medical Center, remains open Tuesday through Thursday, Tuesday, Wednesday, and Thursday from 8 a.m. until 6 p.m. and Friday from 8 a.m. until 5 p.m. Maine Health is continuing with its public-facing vaccine clinic at 110 Free Street on Wednesdays in the month of February from 3 p.m. until 6 p.m. And starting tomorrow, Maine CDC public health nurses are working in partnership with Penn Bay Medical Center and will be holding a vaccine clinic in Thomaston every Thursday in the month of February. This clinic is open from noon until 6 p.m. at the Hampton Inn at 190 New County Road. All of these clinics vaccines are available free of charge at all of these clinics, and walk-ins are welcome. Commissioner, I'll turn things over to you.
Thank you. Last Friday, Governor Mills launched a new pilot project with the Rockefeller Foundation to mail 125,000 free COVID-19 tests directly to the homes of Maine people most in need, improving access to testing in vulnerable Maine communities. Through Project Access COVID Tests, 25,000 Maine households will receive 5 at-home rapid tests. No payment information is required. Both the tests and the shipping are free to eligible residents. The tests will be delivered through Amazon approximately 1 week after ordering. The tests require a quick swab inside each nostril with the results available in minutes. Any individual over the age of 2 can use these tests. Residents in approximately 1/4 of all Maine zip codes are eligible for these free tests through this month-long pilot. People could start ordering last Friday, and as of midnight yesterday, 8,500 tests have been delivered in Maine, with another 30,000 in transit, which is about a quarter of the number available in this month-long pilot. We urge Maine residents, especially those in rural areas, to go to www.accesscovidtests.org and enter your zip code to see if you qualify for these free tests. No matter where you live in Maine, you can order 4 free at-home COVID tests from a nationwide program launched by President Biden. Orders will usually ship between 7 and 12 days, so order your tests now so you have them on hand when you need them at www.covidtests.gov. With that, I'll turn it back over to you, Director Shah.
Thanks, Commissioner. Before I turn to our colleagues in the media, there's one big thing that we wanted to discuss today, which are changes to our contact tracing program. Effective February 8th, the Maine CDC's state-operated contact tracing program for the general public will come to a close. I'd like to take a moment today to talk about why we are making this change and what it means for you in particular. Now, first, a quick reminder on what contact tracing is. Contact tracing is the process of working with someone who tested positive for COVID-19 to determine who they may have exposed, to identify what we all now know as a close contact. Contact tracers reach out to those close contacts, help them monitor their symptoms, and advise them to quarantine. So why are we stopping our state-operated contact tracing program? Well, the decision to bring contact tracing to a close is driven entirely by the science of the Omicron variant, entirely by the science of how that virus spreads, not, for example, at all by the backlog of positive tests that are waiting review. So when I talk about the science of the Omicron variant and how it's different, what do I mean in particular? Well, the Omicron variant differs from prior variants in a few ways that directly impact the effectiveness of contact tracing. First, it's far more contagiousness. It generates up to 3 times as many more cases than the Delta variant, which itself was more contagious than prior variants. Second, the Omicron variant has a shorter period from when you're exposed to when you yourself can start infecting other people. Before Omicron, it took about 3 to 4 days between when you were exposed and when you could start being contagious to others. But with Omicron, it's shorter, by about a day to a day and a half. That means 2 days, maybe 3 days after you're exposed, you can yourself be contagious and be passing Omicron on to others. The third thing that we now know about COVID in generally, but Omicron in particular, is that the majority of transmission happens in the 2 days before people have symptoms and the first few days after they start having symptoms. What I mean by that is that with Omicron, COVID transmission is front-loaded from a transmission perspective, and Omicron more so than prior variants. So what does all this mean? Well, when you take it all together, it means that Omicron is epidemiologically different from prior variants. For example, the fact that it's more contagious means that each infected person generates that many more cases in the community. The fact that the period after exposure, when you become contagious, is shorter means that people start spreading it that much sooner, often before contact tracers might be able to reach them. And the fact that the transmission is front-loaded means that by the time a contact tracer might reach somebody who is exposed, they may have already been spreading it. Also, on top of this, with the US CDC recommending a shorter quarantine period, 5 days now inside and then 5 days with a mask on, by the time that contact tracers reach people, their quarantine period may already be over and any cases they may have transmitted to may have already happened. This is much different from earlier in the pandemic, as folks will remember, when the quarantine period was initially 14 days and then 10 days. The bottom line here is that contact tracing is a race. It's a race between public health and the virus. Who's going to reach people first, us or the virus? Now, until Omicron, that race was fairly neck and neck. But Omicron is a different competitor. The virus that we all first knew about in 2020 has changed. It now has a jetpack on its back. It can be halfway around the track before public health even gets its shoes on. That's important because contact tracing is based on the idea that public health agencies can identify a positive case, get their close contacts, reach out to those close contacts, and advise them to quarantine all before that close contact has a chance to infect and spread COVID to others. But the biology of the Omicron variant is such that contact tracing doesn't get to those folks fast enough, and thus renders contact tracing less effective. Now, we might still win the race against Omicron, but doing so requires different tools like vaccines and masks and testing and a different strategy. Now, if a lot of what I've just said sounds really familiar to you, that's not because today is Groundhog Day. It's because those same scientific reasons motivated our recent changes to school-based contact tracing. Then, as now, the reasons for these changes are scientific and not structural. That is, today's change is not related to the backlog of positive tests. It is driven by the scientific reality of Omicron. Even if we had zero backlog, we would still be making this change. Maine is not alone in doing this either. Other states recognize these same scientific realities and are moving in the same direction. Indeed, the change that I'm talking about today follows a recommendation from various national public health groups last week on this exact topic. So what does all of this mean for you? What does the suspension of Maine CDC's state-operated contact tracing program for the general public mean for you? Well, the first thing is that if you test positive for COVID, you should do the right things. First, stay home, but now make sure you are notifying your own close contacts. What do I mean by a close contact? Who is that? Close contacts are everyone you were around for at least 15 minutes within 6 feet, going back 2 days before you had symptoms or 2 days before you took your test. The second thing is that even though the state-operated contact tracing program is coming to a close, quarantine is not. If you get a call from a friend who you had lunch with the other day, who calls to tell you that they now have COVID and that you are a close contact, you should quarantine if you are not up to date on your vaccinations, namely, if you haven't gotten your booster. The need to quarantine does not change with today's announcement. What does change is that it won't be necessarily Maine CDC who's calling you to inform you that you are a close contact. Contact tracing is not going away for all locations. Certain facilities, like hospitals, nursing homes, jails, prisons, will still continue contact tracing because in those settings, the utility of contact tracing remains high. Nor is contact tracing going away as a mode of controlling infectious diseases. Contact tracing as a strategy for infectious disease control very much remains in place and alive, whether it's for STDs or diseases like hepatitis or tuberculosis. We still maintain a robust contact tracing program for those infectious diseases. What has changed are the scientific realities of the Omicron variant. What all this means is that it's more important now than ever before for everyone to do the right things. Get in touch with close contacts if you get COVID, and quarantine if a friend tells you that they have COVID and you are one of their close contacts. The bottom line is that as the virus has changed, so must our methods to address it. Simply put, we can't tackle 2022's virus with 2019's tools. That's the reason we're making this change, but that also means that each of us has a role to play in keeping a lid on COVID. So with that, I will turn things over to our colleagues in the media. The first question today goes to Annie from Spectrum News.
Thanks so much for taking my question. So I have two things today. You mentioned that you think it's too soon to say whether we're past the Omicron peak. What will you be looking for to think that Omicron is waning, and when do you think that might happen?
So Annie, I think what we're looking for is continuation of the data. So we've got now about an incubation period's worth of data, roughly 2 weeks, and the signs there are encouraging, whether it's on hospitalizations, positivity rates, the number of positive tests coming in, as well as the data that we've started to see on wastewater screening. All of the signs are pointing in the right direction. Here's what I'm looking at. In other countries around the world that also came down from their Omicron surge, the question is how far down do they go? In some countries, they went back to their Delta or pre-Delta baseline. In other countries, like for example, the UK, they came down, but still at a level that was higher than what they were at before. And in one country, at least two countries, Denmark and Norway, they are going the opposite direction, back up. So the question for me is the data right now are encouraging, but we need more of it to really get a sense of what the latter part of our curve will look like.
Great. And just one other related question. We've seen signs of hope like this before, and the virus has bounced right back. How are you thinking about this moment, and how should the public be thinking about it kind of relative to the past 2 years? Is it time to be optimistic or not quite yet?
Well, I'm always an optimist, even in the darkest times. I don't think, and I think the commissioner would concur with me, I don't think you can work in public health and healthcare at a time like this and not be optimistic, always. So I'm always an optimist, but this is part of a broader conversation, Annie, that is not just happening in Maine, it's happening across the country. Different states are having a version of this exact conversation within their borders. We've been here before in some respects, and we may be here again. COVID is down, but it may not be out. So we're going to have to set up systems, which we are doing, that help us figure out how we move out with the long term. That's why, for example, we think that the wastewater screening systems that we've set up, that we've talked about, are really important. These are things that'll help us detect if we ever are in the midst of another surge again. It's too early to tell, and probably too early to talk about what the longer term means. The signs are optimistic, but we still have to plan for the possibility of a resurgence at some point.
Thank you.
Thanks, Annie. Corey, let me go to you from WAGN.
Thank you, Dr. Shah. My first question has to do with, we've seen some reports about Pfizer in particular working on a vaccine for children from the ages of 6 months to 5 years old. So my question with that is, when that is developed, when that is, widespread, what is the metric that you think would be safe? Because that would cover literally all school-age children. What is the metric that you think that they can maybe start to get some back to normal and reducing masking a little bit?
Yeah, Corey, that's a good question. And first of all, we're encouraged by the news that Pfizer is working with the US FDA to bring this vaccine to kids. That is really the last group that's remaining for vaccine eligibility. Certainly, this will come as a relief to so many parents out there who are contending with issues of getting their kids in school and daycare centers. To the question that you raised, Corey, about what it means for things like masking, it's a bit too early to say. Part of it, the availability of the vaccine is definitely a step in the right direction, but we also have to see what it means for reductions in cases overall. So I'm encouraged by this news, and I think it will be welcomed by so many parents. But when it comes to what it means for other things that are part of our mitigation strategy, like masking, it's probably a bit too early to say.
Yes, absolutely. And my next question has to do with transmission rates, especially in children. We're seeing across the country, more and more kids become infected, whether it be the Omicron or Delta variant there. What are we seeing in Maine as far as transmission in kids?
Corey, early on in the pre-Delta, pre-Alpha phase, there was this notion that kids don't get COVID as frequently, nor do they transmit it as frequently. But with the emergence of these newer variants that have come out in the past year and a half, we've seen that notion fall away. Kids in Maine have been getting COVID. They have been transmitting COVID, and that is borne out by the data, partly because vaccination rates are lower in younger kids as, say, in older adults. More and more kids have been getting COVID in Maine, and we've seen that in our case data. Fortunately, relative to adults, kids are not as severely affected. They are affected. They can be hospitalized. But thankfully, the rate of that hospitalization among kids is lower than it is in adults. Now, that's cold comfort for many because it's important to remember that kids aren't supposed to be hospitalized. That's why getting kids vaccinated is such a priority right now. Kids aren't supposed to end up in the hospital. They're not supposed to be severely ill. The vaccine will hopefully, based on the data we'll hope to see, will guard against that.
Thank you.
Thanks, Corey. Let me turn to Emily at the Sun Journal next.
Hi, good afternoon, Dr. Shah. I think actually I'm going to start with a question for Commissioner Lambrou. Can you explain how the various towns and cities in Maine were selected for this program through the Rockefeller Foundation?
Sure. So we were invited to participate along with several other states. And the idea of the pilot is to see if we could succeed in getting into people's hands in areas where there are high risk factors, limited transportation, maybe higher levels of poverty, other sorts of disparities that make it more challenging for those communities to get access to healthcare as well as testing. So we took a look at all those zip codes that are high on what's called the Social Vulnerability Index, picked a threshold, are going to see how many of those households participate. And if we have more tests than we have participants, we'll just continue going and add more and more communities. So we are in the first week of the program. We're excited so far about what we've seen. We do urge people to check it out. It's an easy test. Just go to the website, that www.accesscovidtests.org, and plug in your zip code. You can see if you're eligible for this. But we will evaluate it. We will, if successful, expand it and continue it, because here in Maine, we are committed to trying to ensure people have access to testing. And now that we're in this new phase of the pandemic, where there are more over-the-counter tests, we are going to pivot to try to make sure that those tests are widely available to all people in Maine, no matter where they live.
Okay, thank you. Second question, I think, is actually for both of you. Dr. Shah, you said even though hospitalization numbers are going down, they're still incredibly high. And of course, we have federal COVID response teams and the Maine National Guard. Have you heard from hospitals and healthcare facilities how that's benefiting them and what else they need? Do they still just need more bodies? Is it more supplies? Can you give a snapshot of what it's like inside the typical Maine hospital right now?
Sure. So we do check in with our hospitals regularly, multiple times a week. What we heard today is that the trends that we're seeing statewide are manifesting themselves in hospitals with fairly dramatic improvements in the last week. All that said, as Director Shah said, the levels are still high. So while it's not as stretched as it used to be, it's still stretched. And what we are gathering is that these supports, the federal clinicians that are here in Maine in different communities, the Maine National Guard, other volunteers from our different clinical communities have been helping to alleviate the stress, allow our clinicians to operate at the top of their license, doing the unique medical and clinical care that they alone can do, which has really provided a much needed breath for our hardworking healthcare workers. We are looking hard at what will happen in the coming weeks. Our plan is to keep the Maine National Guard through the end of February, but then we will reassess because we're hopeful by the end of February we can transition to a different model to continue to support our hospitals, but ensuring our Maine National Guard go back to their own jobs and their own lives, because we appreciate their service and recognize it is used when we do have a crisis. And we're hopeful that with the trends we're seeing, that crisis will soon be to a different level.
Okay, really quickly, and apologies if this has been answered. Will ending the state's contact tracing program help at all with the backlog of tests to be processed?
No, the backlog is separate from the contact tracing process entirely. The reasons for ending and suspending the contact tracing program are entirely related to the scientific realities of the virus. It does not intersect with the backlog in any manner.
Okay, thank you.
Thanks, Emily. Patrick, let me go to you next.
Thank you very much. Just wanted to make sure I sort of understood some of the logistics of the end of the contact tracing program. So it ends on February 8th. Is that right?
That's right, Patrick. Yes. The last piece of the contact tracing program will be turned off on February 8th.
So if I could propose present a scenario here, I definitely don't want to invite future variants, but if there are future variants that behave in a way that's different than Omicron, where contact tracing becomes a more useful tool again because it's sort of not spreading so early in the infectious stage, is it possible that we could go back to a situation where the state is using contact tracing again?
Yes. And I don't like to speculate, Patrick, but yep. This is a scenario that we've discussed internally. The particularities of the Omicron variant are what's driving this. Those three factors that I mentioned: hypercontagiousness, a very short, what's so-called latency period after you're exposed to when you can become infectious, and the fact that all of that transmission happens on the front end before people probably even know that there's a close contact. Let's assume for a second that a variant down the line, Tau or Sigma, is in effect the anti-Omicron. Every one of those is flipped. It's slow moving. All of the transmission happens on the back end, and it takes days and days and days of incubating in your body. That's a scenario that we've talked about internally. Those are actually the scenarios where contact tracing is of prime value. That mirrors why we do contact tracing for tuberculosis, HIV, hepatitis, and STDs, because they function with those epidemiological parameters and profile. Omicron is the opposite of that. If some unforeseen, heaven forbid, unknown variant comes down that is more akin to the diseases where contact tracing is of primary importance, then that'll be a sign that we need to bring it back. It won't be easy to bring it back. I don't want to downplay. This is not like turning off and on a switch. It's going to be tough, but that's what we would be taking into account.
I really hope we don't get that far into the Greek alphabet, but
if we do, I'm going to blame it on your hypothetical and say that you jinxed us.
I had friends in Tau Sigma in college. So also, as we move into this new phase of the pandemic, are we sort of entering a place here where we're sort of looking to what the long-term management of COVID-19 is going to be as it reaches potentially an endemic stage? Because we've been doing this for about 2 years now, and we've seen some ebbs and flows, and it's clear we're not in a sprint at this point.
I think that's right. And Commissioner, please chime in, because the Commissioner and I have talked about this. We are just as a country in this place now where we've got to figure out what our goals are with respect to the response to COVID. What are we out there to achieve? the word that you threw around, Patrick, has definitely been thrown around. Endemic. I hesitate to use that word. I think some folks are attracted to it because it has the word end in it. And they, I think, mistakenly assume that when we say we are endemic, we are at the end of the pandemic. Not what the word means. Means something, in fact, almost the opposite. But I think you're right. As a country, as a state, we are in the process of thinking through what are the metrics that we rely upon on the long term? What are the goals of our response? And where do we go from here? But Commissioner, I'll toss it to you.
And I will just add, as Governor Mills said earlier this week, we know people want a sense of stability, a sense of normalcy. And part of our job is to figure out how do we move towards that while still maintaining our public health and the safety of our residents. So we are closely evaluating the trends, the tools that we have at our disposal, and we'll continue to refine them so we more quickly get back to what Maine people love, which is being able to work, to go to school, to play together, to celebrate together. So we are committed to trying to move towards that state as quickly as possible, as safely as possible.
Okay, terrific. Thank you very much.
Thanks, Patrick. Amy Brown, over to you.
Thank you, Dr. Shah and Commissioner Lambrou. Speaking of variants, do you have concerns about what's being called the stealth Omicron, which I guess is not actually a variant, it's a subvariant? And do you have concerns about that or any other actual variants that are on the horizon that worry you?
Not at this time, Amy. You're referencing what's now, or what's called the BA2 lineage. It's a cousin, a sibling of Omicron, not a new variant unto itself. There are some early signs, and you heard me obliquely reference this, from Denmark and Norway, that it may spread even more quickly than the Omicron variant. That has given folks some degree of pause, but the early signs from those countries have not suggested a corresponding increase in hospitalizations, ICU admissions, or deaths. It's still too early to say. Folks are keeping an eye out on it here. We have not detected it in Maine, although it has been detected in a few states in the United States. Whether it is able to outcompete, as the biologists refer to it, the current strain of Omicron remains to be seen in the US. The reason, Amy, although we're keeping an eye on it, that we're not sending up yet any red flags is that Maine's vaccination rate is amongst the highest in the country. It rivals and exceeds that of many of the countries in Europe, even some of the countries that are suffering from this new lineage right now. Our baseline rate of vaccination plus our booster rates, although not as high as other countries, put us among some of the higher vaccinated places. So if this new lineage were to find its way here, the question would be whether it would be able to gain a foothold in the manner that it has in a few places where it's been spreading. Okay, well, that segues well into my second question, which is about second booster shots, and what is the current thinking on a second booster shot now that the Omicron peak seems to be passing, and some people think, there are a lot of people who now have either immunity from having had COVID or from the vaccines they've already received. Yeah, Amy, that's a good question, and the stem of your question sort of suggests the answer. What I've heard in conversations with federal health officials is a little bit less enthusiasm for fourth shots or second boosters for the general population right now. That could obviously change, but right now, today, the combination of so many folks having been infected with Omicron, plus rates of boosters that, at least in states like Maine, are robust, suggest, coupled with the data showing that a second booster doesn't really add too much on top of the first booster, I haven't heard of a lot of enthusiasm toward moving toward that fourth shot. It's too early to say for sure. Things could change. However, one really important note, Amy, for some groups of folks in the United States, fourth doses are already recommended. For folks who are immune compromised, they were authorized for an additional dose back in the fall, their third dose, and then a booster 5 weeks after that. So if you're in that group, if you're immune compromised, you should be out there having gotten your fourth dose. Okay, thank you. Thanks, Amy. Chris, over to you.
Hi, Dr. Shah and Commissioner Lambrou. The first thing I want to ask you, Dr. Shah, because I think we talked about this a little bit last week, was the ability of the Omicron variant to evade some of the protection of the vaccines. And that we saw that when people got a booster, it seemed to bring that protection back up. And I wanted to ask you about the breakthrough cases right now at the Maine CDC. I know that it's been hard to keep track of this data, but do we know of the breakthrough cases? How many of those people have a booster? And because I know in the past you've referenced the majority of the people who are in our hospitals are unvaccinated. I think we said somewhere in the neighborhood of 70%. I'm just wondering if that's still the case with Omicron.
So nationally, and there are some data on this that have been posted by the US CDC. Nationally speaking, when someone gets their booster, particularly of the Pfizer or the Moderna vaccine, so-called Spikevax now, their rates of being hospitalized fall even more dramatically than if they had just had their first two shots alone. Indeed, Chris, in a paper from a few weeks ago, researchers from across the country found that getting your booster reduced your likelihood of being hospitalized by 90%. And that's already reducing it from a pretty low place. Now, here in Maine, we attempt to try to find out if folks have had their booster or not. It's very difficult. So we don't characterize the data in that manner. What we've found, as what all states have found actually, is that understanding the impact of boosters is better done via a controlled clinical trial rather than sort of abstractions of data state by state. That's why we rely on these types of vaccine efficacy studies to really understand the import of boosters rather than just data polls from different states that may be collecting it differently.
Okay. And just to follow up on that point, there was one part I had mentioned about the percentage of people in the hospital unvaccinated. Is it still around 70%?
It's changed a little bit, Chris. It's come down just a bit. It's closer to about 60% now. It does change week to week as new data come in, but it's on the order of about 60% of people right now who are hospitalized in Maine who are not fully vaccinated. It's gone down as low as 55%. And in some weeks, it's been as high as 91% earlier in the summer. We'll have new data on that front tomorrow.
Understood. I obviously wanted to ask you about the vaccine for those young kids. We've talked about it several times. You explained kind of the detail about the severity of their cases last week. I did want to ask you this. We've seen already I want to compare the vaccination rates for those 5 to 11. Right now, statewide, it's about 36%, according to the Maine CDC dashboard. The vaccine's been available for that age group, 5 to 11, for about 3 months now, all of November, all of December, all of January. One, I'm hoping you can put that number in some context to see how do you evaluate that? But two, I think there are parents out there who initially were hesitant to get their kids vaccinated. And I think there are parents out there who are going to look at this new vaccine for this even younger age group. Some are very excited about the prospect of it. I think there are others who will say, well, wait a minute. Kids, even though they're getting COVID, are not as severe as adults. And there's so many people in Maine vaccinated that all the people around my kid are protected. Why should I get my kid the shot? And I'm just hoping you could address that.
Sure. Let's start with the data piece, Chris. Last night I was reviewing some survey data that the Kaiser Family Foundation had just compiled, asking parents of the kids in this newest age group, 6 months to 5, their willingness to get their kids vaccinated. And they compared it to a similar point before the 5 to 11-year-old group had gotten approved. And what they found is that nationwide at that time and now with this newest group, about 1 in every 5 parents, about 20%, have indicated an interest in getting their kids vaccinated. But indeed, when you look at what's happened, as you referenced, the actual numbers are higher than that, 35, 36% in Maine, and that's among the higher across all states. So what this shows is that based on the communication that we put out, the work we do to brief people on the facts of the safety of the vaccine, we can have a part in getting people on board with the vaccine. Now, I'd like to see that 36% number higher. We all would. And we're not slowing down. We're still trying to make sure that vaccines are available. That's why I took time a moment ago to note where vaccines are available. But we've got more work to do there. But I think that same push that we took with the 5 to 11-year-olds can be replicated with the 6 months to 5-year-old group, which is to say, make sure parents know that the vaccine is safe and effective. To the second point you raised, Chris, why it's important for them to be vaccinated. You're right. Others may be vaccinated in a child's life, but that still doesn't mean the child won't be infected. The safest route to take is to get a child vaccinated.
Understood. Just a quick yes or no question, I hope. When we talked about the vaccine for kids 5 to 11, we talked about school-based clinics as an effective way to widely distribute it. Now, these kids, 6 months to 5, if it gets the proper approval and so on and so forth, the emergency use authorization that it's seeking, would those school-based clinics still be the appropriate venue or maybe the most effective venue to get those kids the shot, or is there another way?
Chris, we can't say for sure yet. We're talking to parents now to understand what their preferences are. We have heard, even with the 5 to 11-year-old group, that the younger kids, many parents preferred to take those kids to their pediatrician's office to get the shot from a doctor that they know. It's too early to say really right now, Chris.
Okay. And then just your evaluation of the wastewater data, what you're seeing in it, how it's going. That's all.
It's going very well, and we're seeing reductions in the level of COVID-19 in wastewater that mirror and perhaps even precede the reductions that we've seen in hospitalizations, positivity rates, and new daily cases reported every day.
Thank you very much.
Thanks, Chris. Megan, let me go to you next.
Hi, thanks for taking my question. Chris actually asked one of the questions that I was going to ask, so I'm just going to pivot quickly. But with the full approval of the Moderna vaccine. I know when that happened, I think it was over the summer, the Pfizer vaccine got full approval, and there was just kind of a slight bump in people who got vaccinated. Wasn't anything huge because we'd been hearing, a lot of people were concerned about this emergency use authorization. It was too fast. It didn't have full approval. So now that, that's the case for Moderna, are we, stepping up any kind of vaccine effort? Do you expect any kind of bump? How do we prepare for that if there is one?
Well, if there is a resurgence in interest now that the Moderna vaccine has received its full FDA approval, we want to be ready for that. That is in part, Megan, why you heard me mention this in connection with Chris. That's why I wanted to take a moment to recount the various places across the state of Maine where all the vaccines, in particular, the newly approved Moderna vaccine, Spikevax, is available. We hope that the mark of full FDA approval provides an extra measure of reassurance for folks who are maybe on the fence. FDA doesn't take this lightly. They review reams of data from millions of people who have received the vaccine to ensure that it's both safe and effective. The seal of approval for some is what might have been what was keeping them back. And so if they are now ready to get vaccinated, which we encourage, we want to be there to meet that demand.
Okay, just quickly, we had reported maybe a week or so ago that we were getting a double amount of the monoclonal antibodies to the state, but we weren't quite sure at that time whether or not that was a one-shot deal or if that was going to continue. Can you speak to that? Do we know if that's something that's part of our strategy going forward?
Thanks for bringing that up, Megan. It has continued, thankfully. Commissioner Lambrou and I, as well as Governor Mills, have continued our work to ensure that federal officials have a clear view of what the picture of COVID-19 is in the state of Maine. Federal officials have seen that, and our allocation of that monoclonal antibody, sotrovimab, will continue at with what we got last week, which is 120 patient courses.
Thank you.
Thanks, Megan. Joe Lawler, over to you.
Yes, hello. Happy Groundhog Day, the movie version. I wanted to really understand, I know you said that the reasons for ending the contact tracing are unrelated to the backlog, but does the ending the contact tracing, does that affect the ability to go through the backlog? And if not, can you explain why that is?
Sure, Joe. The answer is that no, it does not. The cessation of contact tracing does not affect the ability to work our way through the backlog in direct terms. It might free up a little bit of time for one of our epidemiological managers, but in general, no, it doesn't. There's not a direct relationship. Again, the cessation of contact tracing is entirely because of the scientific factors that underlie Omicron. Other states are doing this. We've already done it in schools. It's recommended by leading public health organizations at the national level, simply recognizing that the utility of contact tracing is lower now because of Omicron. The reason that there is no intersection of those is that the reduction of the backlog is effectively taking positive case results and converting them, positive laboratory results, and converting them into what the US CDC deems to be a case. And that's a technical process. It's not a clerical one. It's one where we have to design an AI bot that will review all of those and abstract the data from those various positive results and then move them into the format that the US CDC requires for them to be reported. It is not a clerical matter. It's not something where even if we just hired a team of people, that they'd be able to plow through it. At this stage, what it needs to be, and what other states did much earlier because they stopped case investigation altogether, is that it just needs to be automated. And that's a very specialized technical process.
So I guess you mentioned case investigation. So case investigation is different from contact tracing. So case investigation affects the backlog?
That's right. So case investigation, Joe, is the process of getting in touch with somebody who's been diagnosed with COVID, understanding where they may have acquired COVID and who their close contacts were. Many states stopped case investigation entirely very early on in the pandemic because they faced an onslaught of cases. Maine has always found there to be value in case investigation. It's how, for example, when folks say, where are you seeing people getting infected? It's how we're able to say, well, this is where people are reporting they are infected. Now, in light of the Delta surge, as well as more recently Omicron, we've had to pare back on case investigation, but we haven't turned it off entirely because we still, again, think there's some value. We've reduced it, but we haven't turned it off. Automating it, what that will essentially help us do is clear through the cases that we opt not to investigate. We will still do some degree of case investigation even after we move toward automation, because again, we think it's important. We think it's important to know that if someone lands in the hospital with COVID, we understand how they got there and how they may have acquired it. But what automation will do is help us reduce the number of cases that we're not investigating.
Okay, sorry, I promise it won't be much more longer. So contact tracing is part of the case investigation or not at all related to case investigation?
They are distinct but parallel processes. Case investigation works with the individual who is positive for COVID-19. That one of the jobs of case investigators is to elicit close contacts. Those close contacts are then given to a separate team, a contact tracing team, which works with those close contacts to monitor their symptoms and make sure that they are in quarantine.
Okay, thanks. So do we have an idea of when the automated process would start? That's my last question. Thanks.
It's underway. We are working. We're committed toward doing it, and we've cleared the decks for the team of specialists that's working on it to be fully committed to getting it done. I don't have a date right now, though, Joe. Let me go to Patty White next.
Thanks, Dr. Shah and Commissioner Lambrou. How many contact tracers currently work for the CDC, and are you going to retain that workforce and they'll just focus on other diseases, or will that be reduced?
Great. Patty, there are 23 contact tracers right now. 20 of them will be retained by the Maine CDC, and there's 3 others who may or may not stay on with us. We're working with them to see if they'd like to, and if so, what might be a good fit for them. Now, of those 20 who are staying, they won't necessarily be contact tracers in other disease areas. They'll be distributed across the agency, maybe working on other parts of the response or perhaps an entirely non-COVID related matter. We're still working with those, but 20 of those 23 have indicated that they'd like to stay at the Maine CDC.
Okay, great. And will they also actually, you said that contact tracing will still happen in prisons and things like that. So will those contact tracers work in those areas?
No. Contact tracing in specific facilities, be it hospitals, long-term care facilities, nursing homes, jails, and prisons, those are handled by the facilities themselves, not the Maine CDC. What's coming to a close today is simply the state-sponsored contact tracing for members of the general public. Those site-specific contact tracing efforts will continue, but those are managed and overseen by the facilities themselves.
Okay, thank you.
Thanks, Patty. And the last question for the afternoon goes to Brian Sullivan.
Hey, Dr. Shah. A lot of it's asked and answered so far, but I guess I'll just, if we talk in 2 weeks and things continue going this way, I guess when and if we talk in 2 weeks, what are you looking at the most? What statistic do you think is the most of the moment that would show you that we're going in a direction that you like?
You know, Brian, at 6 a.m. this morning, my clock radio went off and Sonny and Cher were playing. And this is exactly what I was thinking about. Going forward, what are the metrics that will tell us the most? And I think the ones that we've talked about thus far, Brian, over the past couple of weeks are the ones that our team will be looking at, namely hospitalizations, and then particularly the fraction of folks within hospitalizations who are in the ICU or on a ventilator. And then I really think wastewater screening data will tell us quite a bit, because wastewater screening data are independent of testing data. The wastewater data don't care who's showing up to get tested, whether they're asymptomatic or symptomatic, et cetera. The wastewater gives us a true population baseline. So that coupled with hospitalizations, I really think those are the metrics that we're going to be looking at.
Okay. I would just end it by letting you know that one of my colleagues interviewed Garth Brooks last week, and he said that by May, when he plays Gillette, we're going to be in an endemic. The pandemic will be over with. So I was wondering if you could just, if you talked with Garth, or you could confirm that.
I do not speak with Mr. Brooks, have not spoken with Mr. Brooks, happy to speak with Mr. Brooks. But there too, you know, that word gets thrown around a lot. And I think people like it because it has the word end in it, but it may not mean what you think it means. So we got to talk more, maybe at another time, about what the last phases of the Omicron surge look like and whether that necessarily means we're going to be in endemic phase.
Okay, thank you.
Yep. Thanks, Brian. Commissioner, I'll toss it over to you if there's anything else to wrap us up with for the afternoon.
Sure. So I'll end on a note of optimism. We learned in the last week that the Moderna vaccine is fully approved and that a COVID-19 vaccine may soon be authorized for that last age group, kids under the age of 5. And we're seeing easier access to affordable home testing. These new tools, on top of Maine's still high performance in containing COVID-19, mean we may soon be entering a state of stability and normalcy. But it takes action. So please get a shot, get a test, and wear a mask. Thank you.
Thanks, Commissioner. And thanks to everyone for taking some time out of your afternoon. We appreciate everyone joining us. As always, please be kind, take care of one another. We'll see everyone next week.